Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about xanthoma. Definition: a xanthoma represents a focal collection of lipid-laden histiocytes in the dermis or tendons. Clinically, xanthomas located in the dermis appear as yellowish. Xanthos from Greek is for yellow. Papules, plaques, and nodules. Tendon xanthomas are deep, flesh-colored, hard nodules located within peripheral tendons. Xanthomas usually are a manifestation of a hyperlipoproteinemic state. Incidence: flat xanthomas on the eyelids, or so-called Xanthelasmas, are the most frequently encountered xanthomas, but are still not very common. Other xanthomas are even less common, both as a presenting a complaint in a dermatology clinic and as an incidental finding in the general population. Familial hypertriglyceridemia and familial hypercholesterolemia are both inherited as autosomal dominant traits, each at a frequency of 1 in 500 of the general population. Patients who are homozygous for the disease are obviously much fewer in number, but are more severely affected and more likely to have xanthomas. History: in patients with one of the inherited hyperlipoproteinemias, a positive familial history may be elicited. In addition, the patient may have systemic signs and symptoms that accompany the cutaneous xanthomas, including a history of coronary artery disease and diabetes. Patients with eruptive xanthomas have markedly raised triglyceride levels that usually result from a familial metabolic abnormality combined with a secondary factor such as alcohol, obesity, glucose intolerance, hyperinsulinemia, and drugs including estrogens, corticosteroids, and isotretinoin. Eruptive xanthomas appear relatively quickly in several weeks and correspondingly disappear rapidly after reduction of serum triglyceride levels. Physical examination: several types of xanthoma have been characterized. In all except the tendon type, the yellow color of the lesion provides the clue to its lipid nature. Xanthelasmas are yellowish plaques on the eyelids. This is the only type that is not invariably accompanied by an increase in either plasma cholesterol or triglyceride concentration. Eruptive xanthomas are reddish yellowish papules and plaques that occur in patients with markedly raised triglyceride levels. They occur most frequently on extensor surfaces but may appear anywhere. Tendon xanthomas are stony, hard nodules occurring on tendons, most often the Achilles tendon and the extensor tendons of the fingers. Because of their depth, the yellow color cannot be appreciated clinically. Tendon xanthomas are usually associated with severe hypercholesterolemia. Tuberous xanthomas are potato-like papules and nodules which are yellowish and most often found on the elbows and buttocks. Tuberous xanthomas are associated with increased serum triglyceride or cholesterol levels. Eruptive xanthomas: multiple yellowish pink papules in dermis, dense infiltrate of lipid-laden histiocytes can be seen. Tendon xanthoma: hard pinkish flesh-colored nodule on the Achilles tendon. Differential diagnosis: sebaceous glands, lipid deposits, and granulomas are the major causes of the yellow color in skin papules. The lesions of sebaceous gland hyperplasia usually occur on the face as small superficial papules, often with a central application. The yellowish-orange papules and plaques of juvenile xanthogranuloma also contain a lipid, which is responsible for the color. As the name suggests, these lesions occur in childhood and usually involute spontaneously. Extracutaneous involvement is rare. However, multiple juvenile xanthogranulomas in children younger than 2 years of age are more likely to have eye involvement and should be referred to an ophthalmologist to rule out hyphema or hemorrhage and glaucoma. Histologically, they have a distinctive appearance. They are not associated with raised plasma lipid levels. Both rheumatoid nodules and tendon xanthomas are subcutaneous, but only tendon xanthomas are fixed to their tendon structures. Juvenile xanthogranuloma presents as a yellow papule. Laboratory and biopsy. The diagnosis is usually made clinically. All patients with xanthomas should have a screening for fasting lipid profile. In patients with xanthelasma, results are normal in approximately 50%. For the other types of xanthoma, lipid abnormalities are to be expected. The biopsy reveals an infiltrate of numerous lipid-laden histiocytes. Therapy is aimed at lowering the abnormal lipid levels with diet, and for patients with markedly increased lipid levels, medications. Xanthelasma lesions may be removed surgically for cosmetic reasons. The conclusion of therapy for xanthoma include initial therapy is diet and medications like statins, bile acid binding resins, fibrous and nicotinic acid oniocin, and alternative therapy include surgery. Course and complications. Eruptive xanthomas involve spontaneously after lowering of the serum triglyceride concentration. The other types of xanthoma are more persistent but may slowly regress if the lipid levels are lowered. The cutaneous lesions usually have no complications, but the lipid abnormality may be associated with significant systemic complications such as premature myocardial infarction in patients with raised cholesterol levels and pancreatitis in patients with markedly increased levels of serum triglycerides. Pathogenesis. Xanthomas represent the accumulation of lipid-laden histiocytes. The lipid is thought to be extracted from plasma, although some evidence suggests that intracellular lipid synthesis may also be operative in some instances. Patients with familial hypercholesterolemia have increased endogenous hepatic production of very low-density lipoproteins or VLDLs, which are particles with a high triglyceride content. In these patients, VLDL production is further increased with high carbohydrate or alcohol ingestion, obesity or diabetes, or triglyceride levels of more than 2000 mg per milliliter may be attained. Triglyceride deposits are polar and thereby most susceptible to intracellular lysosomal hydrolysis. Hence, eruptive xanthomas quickly resolve when the triglyceride level is lowered. Patients with familial hypercholesterolemia have high levels of circulating low-density lipoproteins or LDLs, which are particles with a high cholesterol content. In these patients, the gene affected is the one that controls the synthesis of LDL cell surface receptors. As a result, LDL cannot be adequately removed from the plasma by cellular uptake. In addition, the cells perceive an intracellular deficiency of LDL and hence are stimulated to produce more LDL, a process resulting in even higher serum levels. Individuals who are heterozygous for this disease have plasma LDL levels that are 2 to 3 times the normal level and develop tendon xanthomas and premature atherosclerotic cardiovascular disease in midlife. Homozygotic patients have plasma LDL levels that are 6 to 8 times normal levels, with cholesterol levels of greater than 800 mg per deciliter, and they develop symptomatic coronary artery disease before the age of 20 years. The non-polar cholesterol esters are more resistant to degradation and therefore persist in both skin or tendon xanthomas and blood vessels or atherosclerosis. Clinical case: a 52-year-old man presents to the clinic with yellowish painless skin lesions that have gradually appeared over the past year. He has a history of poorly controlled diabetes mellitus and hyperlipidemia. On physical examination, there are soft yellow plaques on both upper eyelids and yellowish nodules over the extensor surfaces of the elbows and Achilles tendons. Laboratory tests reveal markedly elevated LDL cholesterol and triglyceride levels. Which of the following is the most likely diagnosis? A. Seborrheic keratosis, B. Xanthoma, C. lipoma, D. neurofibroma, and E. dermatofibroma. As we know, the correct answer is B, or xanthoma. An explanation: xanthomas are lipid-rich deposits in the skin and tendons caused by disorders of lipid metabolism. They appear as yellow papules, nodules, or plaques. Common types include Xanthelasma, which is xanthoma or eyelids, and tendons. Xanthomas are usually present on Achilles tendon and extensor tendons, and eruptive xanthomas, which are associated with very high triglycerides level and often associated with hyperlipidemia, diabetes, and cardiovascular disease. Differential diagnosis: seborrheic keratosis is a brown stuck-on varicose lesions. Lipoma is a soft mobile subcutaneous mass and is usually skin-colored. Neurofibroma is a soft papules or nodules and may show buttonhole sign, or buttonhole sign is the diagnostic for neurofibroma. And dermatofibroma is a firm nodule with a dimpling on lateral pressure. Okay, this was an explanation about xanthoma. Thank you for your attention.